and some CT guidance. And so there's multiple MSK fellowships that are offered basically from coast to coast, everything from Vancouver out to Dalhousie. And it's also offered in the States via the match, which happens at different times. And we can kind of go into that a little bit later on if that's of interest to any of you. So what does the average day in my life look like as an MSK fellow? So for me, obviously there's going to be a bit of center variance when it comes to this. But for me, my work hours are generally 8 to 4. And very rarely do I end up leaving work after 4:30. And usually I'd get in about 10, 15 minutes, maybe 20 minutes before, just to do some pre-protocoling and some prep for the day. So I get 2 days a week of diagnostic cross-sectional imaging, usually mostly MRI, although some CT, and then with supervised cases tossed in. So supervised cases, for those of you who don't know, are they tend to be like bone lesions or soft tissue lesions where you might want to alter the protocol based off of what you're seeing, and might want to pick different planes depending on where the lesion is. So instead of just having a standardized protocol where you say, okay, just do a knee, you'll be like, okay, I want a T1 in this plane through this area and a stir in this plane through this area, and try to sort that out that way. I get 1 day a week of ultrasound. Sometimes it's a diagnostic day, sometimes it's a procedural day. So for example, guided ultrasounds that we tend to do out here, lots of shoulders, some knees, some hips, some elbows, especially for things like distal biceps tendon or tennis elbow. And for ultrasound guided procedures, a lot of bursa injections and some joint injections as well. And then I get 1 day a week of fluoro procedures. So this is mostly under the umbrella of pain management. So a lot of corticosteroid injections, some Durolane injections, some PRP or platelet-rich plasma injections. Basically any joint you can think of, I've injected at this point in time, including the sacrococcygeal joint, which, well, you know, a little bit of a pain in the butt, so to say, for that patient, but we fixed that. And then one last day of the week for me is a wild card. Sometimes it's research, sometimes it's an extra ultrasound or an extra diagnostic day, all depending on what exactly I ask for, which is kind of nice. And then my call is not as bad as resident call. It's mostly plain film and MSK and spine MR coverage. Usually 1 weekday per week and 8 weekends in the overall 12 month period. So very manageable and definitely a lot more chill than resident call. So the skills and knowledge that you might develop over an MSK fellowship. So you're there ultimately to figure out to develop your expert opinion on the various different pathologies that affect bones, joints, muscles, tendons, the whole like. So you become kind of that person, that go-to person within a practice for any of those entities, especially something that's kind of veering away from the usual kind of ordinary garden variety stuff. One of the nice things about MSK is that we utilize every single modality out there. Everything from the plain film, which can provide quite a bit of diagnostic information and quite a bit of insight into a lot of our pathologies, up to MR, ultrasound, CT, all use dual energy CT. There's a lot of nuke stuff that ties in as well, which obviously the nuclear medicine residency addresses that completely, but we do some correlation with that too. And then minor procedures. So if you're the type of person that's like, hey, I like doing some minor procedures, but I'm not a big fan of angio IR work, then definitely consider MSK. We do procedures under fluoro, ultrasound, CT, bone biopsies, joint injections, the whole like nerve root injections, Achilles tendon stripping. There's the amounts of procedures that we end up doing is vast. It's a lot more than I thought were possible really as a resident. So that's kind of neat. And then there's also, you know, some patient skills, some patient interaction, especially when it comes to the pain management side of things, you know, being able to, you know, obtain a succinct history, make sure that, you know, you can consent a patient and make them feel at ease, and then hopefully be able to alleviate some of their pain as well. And then MDT conference skills, which come with a lot of residency and fellowship training. For example, I participate in sarcoma rounds every 2 weeks and rheumatology rounds every month, and, you know, act as the as the radiologist presenting those cases for those rounds. So quite a bit of opportunities to practice developing those kind of presentation skills and that kind of thinking on the fly when it comes to these less than typical cases. So I've alluded to this all throughout my kind of talk here, but why did I pick MSK? I love the variety. We use every single modality. It's not something like, I don't want to bash other modalities, but there's certain ones like chest that are very CTA dependent and don't really utilize MR. So it kind of keeps up all your skills across multi-modalities. I love the ability to have a couple procedural days a week, but not having the high acuity and stress that comes with a lot of the angio work and IR. I find MSK studies overall are a little bit quicker to interpret than, say, your cholangiocarcinoma MR, where you might spend a lot of time trying to parse out the anatomy and try to parse out everything else like that. I personally know that I have a shorter attention span when it comes to things, so it's kind of nice to be able to be like, all right, meniscal tear, ACL's gone, this, that, the other thing, next study. I find that quite fulfilling for me, so that's personal dependent. It's highly collaborative. We talk with a lot of ortho, with rheumatology, and a lot of other different services, and provide kind of a bit of patient care and a bit of guidance that way. And one of the things that really steered me towards it is that this type of fellowship is very sought after for both academic and community practices. You provide a lot of value when you come with an MSK fellowship, because a lot of people are, a little bit more shaky on the weird and wonderful when it comes to MSK pathologies. So it's kind of nice, and you're highly sought after with that. You also have the ability to go private should you wish to, and you can also find jobs without call. If you also want to do that as well. There's a few different practices I know out here in Alberta that do purely mostly pain management and outpatient imaging where there's no call involved. So if that's something that you kind of want to steer away from in the future, you might be able to in this field as well. Now the drawbacks, some of these are kind of funny, and very much person dependent. So I know when I came into radiology, I was the type of person that I could take or leave patient interaction. I didn't find it necessary for my own job satisfaction. And there's quite a bit of patient interaction here and quite a bit of interaction with other people, which is sometimes great and sometimes a little bit more than what you'd like. You do have to wear lead for a lot of those procedure days, especially the fluoro ones. So, a little bit of muscle aches and soreness. And then really this last point kind of applies to any fellowship. Whenever you do a deep dive into one area, you kind of lose a little bit of your skills in other areas and a little bit of nuance. So depending on what you think your practice might look like in the future, it might be helpful to have a fellowship or might not be, but that's 100% something that you need to decide for yourself.
Okay, so hi everyone. My name is Carilne Rutten, and I'm currently the Chief Fellow at Sick Kids in Pediatric Radiology. So I did my med school and residency training in Paris, in France, and arrived here for a fellowship. My decision to go into subspecialty was not an easy one. So good luck to all of you, because I know how much of a struggle it can be. And I definitely went back and forth a couple of times. So when I was in med school, I rotated through peds, and I wasn't particularly enthused by peds medicine. It can get messy. Children cry. So I never considered going into peds. But then came residency, and we had this mandatory rotation to do in peds radiology. And to my surprise, I discovered that I enjoyed the environment. It was very calm and friendly, a bit more so than the adult environment. I found that there was a really good communication with the clinicians, where they would listen to the opinions we'd give. We'd discuss not only whether imaging was indicated, but which imaging modality would be the best. And the cases that did come to imaging felt more filtered to me. The children had been examined, and so they had when there was pathology, you know, it's usually it was interesting pathology, and it made the imaging feel very relevant right from the get-go. I remember a couple of cases, you know, in the middle of the night or during residency in adult ward, like I was doing a thyroid ultrasound for a 90-year-old patient, and wondering sometimes, you know, what's the relevance of the imaging that we're doing, and especially if we're not filtering the exams very much. And in peds, it felt different, and I really enjoyed that. I also thought that it was fun to work with a huge age range, from very preterm babies with very different pathologies, all the way to teens, where the pathologies overlap with adults. And I thought that it was nice to, you know, do a bit of everything. You know, there's a bit of MSK, a bit of neuro, a bit of body, a bit of women's imaging, also core cases with child abuse. So all in all, it felt very precious to me. Then it got to the end of the rotation, and like I started discussing, you know, you're going to stay on for a fellowship here, and like I'd never considered doing this as a career. I was worried about not being able to go and work in the community. I was worried about the fact that, well, you don't get paid quite as well when you're working in the hospital. I did enjoy adult cases, and I enjoyed locuming during residency, and, you know, discovering that, you know, it's nice too. So I very much struggled, and I got to the end of my 3rd year of residency, and I still hadn't made my mind up. So I went for another rotation in peds, and there I sort of discovered that, yeah, it made sense for me, because it made me feel very fulfilled. It's for me, there's something about pathology, is especially in children, that feels that felt a bit more relevant to me sometimes than working in the adult world, and the ability that you have sometimes to make a good diagnosis. You can change the entire path of that child's life with management, and that felt wonderful. So for that reason, I went into peds, and that's where I'm specializing right now. It's great. We have, especially at sick kids, a huge diversity of cases, all body systems, and all imaging modalities. These are just like some of the cases that I've had over the past month. So that diversity and that ability to play around with different systems keeps things very, very enthusing, and I find it very fun. And the environment is very, very precious. I was on call this weekend, and on Sunday evening at 10 p.m. we got this email from a clinician saying, "Thank you for your help today. We CT'd a child who had a suspected lymphoma recurrence," and she thanks us at the end of the day, mentioning that, you know, it changed patient management, and to work in an environment where the clinicians, where there's that much communication with the clinicians, and where they recognize your role, is just, for me, incredible, and it makes life in the hospital fantastic. We're also this is our fellows group this year with some of the staff. We're very close knit, and, you know, it works the same way with the clinicians too. I have cell numbers of all of the surgical fellows. We communicate, we're very close, and that sort of makes up for one of the disadvantages of the specialty, which is that it's an on-call specialty in the academic centers. But with the calls, you also get very, very interesting cases too. So I guess it's just part of hospital. You've got my email address.
Next, if you're all ready to go.
Yes, I'm going to share my screen.
Awesome.
There we go. So just a little introduction here. So I'm a
Joyce, just before you keep going there, we're seeing your presenter view. Is that okay? We can just see your notes, but I guess there aren't any notes.
there's no notes. How does it look like this?
That's just like the PowerPoint. Like we can see the slides on the side.
Slides on the side. Okay. Then I guess it's fine. There's no notes.
Okay. Perfect.
Nothing to write.
Yeah. Great.
No problem. But yeah, so I'm an interventional radiology fellow. I'm currently doing my fellowship at in Toronto. So with the University Health Network in Mount Sinai Hospital. So I'm going to talk a little bit about interventional radiology, which is kind of like an exciting specialty of radiology, and it's like very attractive right now because we do a lot of procedures. We have a lot of contact with patients, and we could go from very basic bread and butter procedures to very like high-end and cutting-edge techniques. So I'm going to kind of go through a little bit, and I'll talk a little bit about how it works when applying to an interventional radiology fellowship program, and a little bit what was my kind of like journey through residency to getting into interventional radiology. So this is a picture of the angio suite. So what is IR? I guess at this point, most of you kind of know what IR does. There's a lot of like vascular and non-vascular cases that we do. So in all the non-vascular procedures, we could do like percutaneous, image-guided procedures, nephrostomy, ciliary tubes, cholecystomy. Like it never ends. We could do ablations of liver tumors or even kidney tumors, and now there's even ablations for soft tissue lesions. And then we get into more complex endovascular procedures, which kind of makes us a little bit different from other subspecialties, such as the peripheral vascular disease. We deal with a lot with venous diseases. There's a huge component of oncology, all these kind of malformation, aneurysm, bleeds. So it's very dynamic. We do a lot of collaborative work with the clinicians, a lot of multidisciplinary rounds, and we're in tune a lot with our diagnostic colleagues, and a lot of us still maintain our diagnostic skills because most of us go into community practice where we kind of do a little bit of diagnostic and intervention all combined. And obviously there's a lot of like education in it and research if people want to go more into the academic route. So we do basic stuff like PICC lines and these porticats, dialysis catheter insertions, nephrostomy tubes. I'm just kind of going quickly over this, but then we can get into really cool cases like, for example, these traumatic like arteriovenous fistulas, like here in the liver, how we go and we embolize these and like treat patients that have like complex vascular malformations, whether it be congenital or traumatic, like in this case. Or we go and we treat aneurysms of the kidneys. So a lot of cool techniques, a lot of cool equipment that we use to do things. TIPS is another cool procedure. It's actually my favorite procedure in interventional radiology, where we kind of place the stent and connect the hepatic vein with the portal vein to try to help patients with portal hypertension. So in patients with cirrhosis or like liver disease, a lot of peripheral vascular disease. So yes, there's a lot of it being taken up by vascular surgeons, but in certain centers, like in my hospital, like where I'm doing my fellowship, there's a lot of like collaborative work between the interventional radiologist and the vascular surgeon. So we do a lot of high-end aortic and peripheral arterial work. And then again, like this is just basically showcasing these like pulmonary vascular malformations and how we treat them. We could all these embolizing equipment like plugs and coils, kind of like this. And this is kind of like a GI bleed. So we deal with a lot of patients that are unstable in ICU. So it's also that one of that subspecialty that 2 a.m. you can get a phone call from ICU, patient is bleeding out, acute, it's very acute, fast-paced kind of specialty. Got to get up, got to go to the hospital, manage the patient, treat the patient, and right away while we're embolizing the patient, you see right away the patient is doing better. The vital signs are normalizing. They're getting off the faster. So we have an immediate effect on the patient's clinical status, which is very rewarding. And what I'm trying to showcase here is that there's like a GI bleed. So here there was like an active extravasation when we interrogated. This is the superior mesenteric artery that was interrogated. So in this case, it showed that there was an active bleed. And then we went in and we embolized with some coils. And right away, the active blush is gone and the patient did much better, ended up getting off plasters and eventually leaving ICU. So it's very rewarding of a specialty subspecialty of radiology. It is a quite intense subspecialty. Like I said, we do get those phone calls at 2 a.m. Certain fellowship programs, more intense than others. I would say that my program at UHN Mount Sinai Toronto is known for being the most intense. So there have been some weekends where I've had 4 hours of sleep in 3 days. That does exist. There's no post calls. It's quite of intense and work hard kind of environment. But we get to see a lot of stuff and we get to help a lot of patients. It's very rewarding. We are also a referral center from across the country. Everything kind of pulls down to Toronto. So we get very complex cases that other people don't want to touch. It comes to our hospital and we have to manage patients. So it always keeps you on your toes. So how to get into interventional radiology? Things are shifting, and I'm just going to go really quickly. So that's either that you do your 5 year of residency and then you could do a year or 2 years of fellowship. And now they're trying to integrate these residency programs, so meaning that after your 5 years of diagnostic residency, some programs are integrating a 6th year or even a 7th year of interventional radiology residency program. That's almost an equivalent to doing a fellowship. So things are kind of moving towards that. So if you guys have any questions regarding that, we can talk about it. Then it's how to approach your electives during residency to kind of know if you want to do interventional or not. It's important to kind of you'll have 3 obligatory interventional radiology rotations during your residency. So it's always a good introduction to see if you like it or you don't. And then from there on, you can do more electives and kind of get engaged with the team and try to do more procedures. The more procedures you do, the more you kind of get this hands-on and you kind of understand a little bit what's interventional radiology all about.